For those joining us, we are having some YouTube technical issues, and we are on a brief hold while we resolve those issues. Yes, Ms. Withy.
We are all good to go. Thank you.
Excellent, thank you. So we will resume Monday morning in HHS, and let's see, where did we leave off? I think we will just dive into introductions, and we'll start with Representative Zager.
Thank you very much, Madam Chair. My name is Sam Zager, honored to represent District 41, including the Portland neighborhoods of Deering Center, Deering Highlands, Woodford's Corner, Libbytown, Oakdale, Rosemont, and the University of Maine Law School.
Representative Lemelin.
Good morning, everyone. My name is Michael Lemelin. I represent District 88, Chelsea, Jefferson, Whitefield, and half of Noblesboro.
Representative Stover.
Good morning. My name is Holly Stover. I represent House District 89, including the towns of Boothbay Harbor, Southport, Edgecombe, Westport Island, and part of South Bristol.
Representative Perry.
Good morning. I'm Ann Perry. I represent House District 140, which includes the communities of Indian Township, Baileyville, Barron, Calais, Charlotte, Robbinston, Perry, Pembroke, and Pleasant Point.
Representative Connor.
Thank you, Madam Chair. Good morning, everyone. My name is John Connor. I represent House District 58, which is part of Lewiston.
Representative Craven.
Thank you, Madam Chair. Good morning. I'm Margaret Craven, and I represent House District 59, which is part of Lewiston.
Representative Javner.
Good morning. I'm Representative Kathy Javner, and I represent House District 141, which is located in Penobscot and Washington counties.
Representative Griffin.
Good morning. My name is Abigail Griffin. I represent House District 102, which is Glenburn, Levant, and Cadescade.
Senator Moore, are you available to introduce yourself?
I am. Thank you, Representative Meyer. This is Mary Ann Moore, and I represent Senate District 6, which is all of Washington County, as well as Goldsboro, Winter Harbor, and Sullivan in Hancock County as well.
Thank you. Senator Claxton, did you want to reintroduce yourself, or you're all set?
Good morning. I'm still Ned Claxton, and I still represent Senate District 20, which includes Auburn, where I live, Minot, Mechanic, Falls, Poland, and Gloucester. It's great to be here, and I'll be here for the rest of the morning.
And Senator Moore, do you have your hand up?
I pressed the wrong key. I'm sorry, Representative Meyer.
It's quite all right. And I am Representative Michelle Meyer, serving Southern Maine's House District 2, which is all of Elliott, where I live, and parts of Kittery and South Berwick. I would also like to introduce, yes, our analyst.
Hi, I'm Anna Broom. I'm one of the legislative analysts for the Health and Human Services Committee, and I work in the Nonpartisan Office of Policy and Legal Analysis.
And our clerk.
Good morning. My name is Carrie Withy. I'm the clerk for the Health and Human Services Committee. If you need any assistance this morning, you can email me at hhs@legislature.maine.gov.
With that, I will open up the first of our three public hearings this morning, LD 1649, and welcome this bill's sponsor, Senator Libby, I believe. Welcome, Senator Libby. Good morning.
Good morning, Representative Meyer. Thank you, Senator Claxton, and members of the Health and Human Services Committee. I'm Nate Libby, and I proudly represent all of the people of Lewiston in Maine Senate. I'm here to present LD 1649, an act to make the shared living program accessible for persons with intellectual disabilities or autism. I'm not sure if the committee has heard legislation this year on the shared living program, but this is a program established as part of the Home and Community-Based Services Program, HCBS program, under Section 21 and Section 29. This legislation was brought to me by Representative Denise Tepler from Topsom. She submitted legislation in the last legislature to try to deal with this issue on behalf of a constituent. And that constituent has made their way to my community, and Representative Tepler and I have continued to try to assist this constituent with some of the issues they face around this program. So I'm now carrying it forward in partnership with Representative Tepler. The constituent who has raised this for us is named Josh. I believe Josh will be testifying later today. But he lives in a shared living situation. He has significant physical disabilities. His fiance is also living with him and has significant intellectual disabilities. They've experienced hardship in finding a living situation that has appropriate handicap accessible modifications made for their home. As I mentioned, Representative Tepler had presented legislation in the last legislature. That bill was LD 1944. At the time this committee heard the bill, DHHS testified in opposition, stating that the bill was not necessary, and that triggered conversations with the constituent to try to come up with a resolution. That occurred just weeks before the pandemic hit. Some of that was put on pause. However, I picked up the ball in the fall and tried to facilitate further conversation with the department. Now, just a bit on shared living. This differs from an apartment complex or group home in that it is a family or an individual who chooses to become an independent contractor, who then, as an independent contractor, houses people with disabilities and provides care for them from their own home. In the case of my constituent, he had two previous providers. My constituent reported that the last two providers were given contracts of approximately $40,000 each, roughly, for the state to provide care to him. And one of those two providers was given an additional $10,000 to install a shower that fits Josh's needs. Now, where this gets challenging and where the rub is the provider, the independent contractor who was given the money to do the retrofitting of the shower, had to sell their house as the result of a divorce. So that caused my constituent to need to find another living arrangement in an apartment building. But obviously the number of apartments available with those kinds of modifications is very, very, that number is very, very small. And so, that's the crux of the issue here, is that now that the state has spent some money to get an apartment retrofitted, Josh is not able to be the beneficiary of these modifications in the future, as I understand from the department, because they've already done this once. So there's part of the issue. Can the benefit follow the consumer, the end consumer, or are we going to have limits for this program being available to those folks? So as I mentioned, we did go to DHHS before just filing another bill. We tried to come up with a resolution, but we're unable to. DHHS reported to us that the rules do not allow for funding to be authorized for home modification for an individual. And that's really the crux of what we're trying to address. Last year, as I noted, the department said this bill was not necessary and was going to work with the constituent. So we've been working with the constituent and trying to come up with a resolution and told by the department that the rules don't allow it. So I'm bringing you a bill to change the rules. And now the department is saying this bill would be out of alignment with the current structure of shared living program. And that's true. That's why I'm presenting the bill. It's there's an alignment right now and I'm seeking to change it. So I don't dispute that. But they also argue that the changes proposed are unnecessary. And that's where I guess we have a difference of agreement. So I guess I would close with two final thoughts. If there's a way to craft this bill that is satisfactory to the department, we would welcome it. We had a relatively small group of folks working on drafting this legislation, and we're not well versed in the policy, so we're obviously open to amendments. And then my final point is just to circle back and mention what Representative Tepler had mentioned in her remarks a year ago. And that is that the main goal of this bill is to make this sort of accommodation possible. It allows for persons providing shared living housing to access coverage for resources like ramps and other necessary accommodations that are required by a resident living with disabilities. Shared housing helps combat group home shortages. Group home shortages, as you know, are widespread here in the state. But it helps provide another option for housing that's much more cost effective, much more limited in scope. And so with that, I'm happy to try to answer any questions you may have. We will have folks testifying in a moment from Disability Rights Maine who work in this world a little bit more than I do. And as well, we'll have a constituent testify, so he's able to give his side of the story. With that, I thank you for considering this bill.
Thank you, Senator. Questions for the bill sponsor? Seeing none, we'll hear from Sarah Squires. Welcome.
Good morning.
Morning.
I'm here to present the testimony drafted by Stacy Converse, who's worked closely with Josh on this issue. So I will be reading her comments. Senator Claxton, Representative Meyer, members of the Joint Standing Committee on Health and Human Services. My name is Sarah Squires, and I'm the Public Policy Director for Disability Rights Maine, and I want to thank you for the opportunity for DRM to provide testimony in support of LD 1649. The legislation would make shared living option under Maine's Section 21 and 29 home and community-based waiver programs available to more Mainers with intellectual and developmental disabilities. Shared living is a roommate-like model of support where individuals with disabilities live with the provider and their family. Typically, the person with a disability will move into the single-person home owned by a shared living provider. The provider supports the individual with living skills, personal care, and community engagement, among other things. For these supports, the shared living provider is paid a stipend. Currently, the Department of Health and Human Services pays to a shared living, the rate the department pays to a shared living provider does not vary based on the needs of the individual with disability served. This has had the effect that individuals with high needs are frequently unable to provide shared living providers willing to work with them. This legislation would require DHHS to convene a working group to review the shared living program to determine whether to modify it or to provide stipend rates. If the change were implemented, it could have the effect of making the program more accessible to individuals with higher needs. Additionally, as Senator Libby mentioned, individuals who receive Sections 21 and 29 waivers are eligible to receive up to $10,000 for home accessibility adaptations through the waiver program. In a state like Maine with very little physically accessible housing, these home accessibility funds are essential to individuals who need physical modifications to their residences. Per state and federal law, these funds are limited to properties owned by the individual with a disability or their family and are not available to unrelated shared living providers. The result of this is that many individuals with physical disabilities are unable to move in with a shared living provider because the home is not accessible to them. The legislation would add home accessibility adaptation for shared living providers to an already existing contingency fund. For the foregoing reasons, we support this legislation and urge you to support it as well. Thank you.
Thank you. Questions for Ms. Squires? Seeing none, appreciate up. Representative Craven? Yes.
Thank
Go ahead.
you, Madam Chair. Could you elaborate on the contingency fund? I mean, is that just from the DHHS budget, or?
I'm sorry to say this. I probably am not the best person. In fact, I know I'm not the best person to answer that question. I can forward your request for the information on to Attorney Converse and have her follow up with the committee.
Thank you.
Seeing no other hands up, appreciate your being here this morning.
Thank you.
We will now hear from Josh Weedman. Josh. I see you were unmuted, but
can everyone hear me?
We can hear you, but we can't see you. Now we can.
Okay. First, I want to thank Representative Meyer and Senator Quinkston for you guys' time. It is, from my perspective, very hard to find shared living providers because my CP, not a lot of people want to take care of a person who's physically disabled. The stipend rate is $40,000 per person. If they have to pay for the home adaptations, it's at least $10,000 to $15,000, depending on what you have to have done. So the rate itself is not conducive for anyone to take me in. And in these last two circumstances, the department has given a state contract and a waiver contract, $40,000 each, me and my fiance, plus the $10,000 shower. But the problem with that is when he sold his home, the department gave him that money, but he had to pay it back. And when I tried to ask for the money back, the department said that they didn't have it anymore. And so even though I still needed the shower, I never got access to it because the department denied me access. The contract, the state contract and the waiver contract was offered to two different providers, as well as the handicap accessible shower. Both providers didn't work out. Unfortunately, that meant that I couldn't find another provider that I wanted to have both rates for me and my fiance. They did adjust the rate under the K waiver for emergency authorization only. So there's no way, there's no definite answer if it's going to stay. And so it's been very, very hard emotionally.
Josh, you may be frozen and we're having a very hard time hearing you now.
So I definitely think a higher rate, because am I frozen?
You seem to be having some issues with your connection. And we're having, that's quite all right. It happens all the time.
I'm not used to the Zoom stuff. Did you get a majority of my testimony, or?
We did. Let me ask the committee if they have any questions for you, Josh. Questions from the committee for Mr. Weidman? Seeing none. Oh, actually, we've got two. We've got, yes, Representative Zager.
Thank you, Madam Chair. Mr. Weidman, thank you very much for coming today. I was wondering how you meet up with those who might become shared living providers. What's the how does that get brokered?
Typically the process is to do a vendor call. But I am very tech savvy and also very capable of putting ads on the internet. So I get responses based upon that as well. And that's the same for a group home as well. So that's how they come across that, and that's how they make that determination.
I got it. Thank you very much. Good to see you.
Representative Craven.
Thank you, Madam Chair. My question is for Senator Libby. So I wanted to know if you had spoken to the department about the provider having given the $10,000 back that he had received to install the handicap bathroom, and if he did have to pay it back, why can't they reuse it?
Thank you for the question, Representative Craven. I'm looking at my notes from the department, and I don't know that that particular piece came up in our conversation with Scott at HHS.
Thank you. Thanks.
Can I add a piece of information?
Certainly.
That I think would be very helpful. When I approached the department again for the modification and a higher tiered rate, they said that they would boot me off the waiver based upon the waiver not meeting my needs. So I didn't want to push the department any further because it was kind of, I took that as a threat. I also want to say I'm not the only one in this.
You've frozen again, Josh. We're unable to hear you. Do you want to put your video down so that it's just audio? That sometimes helps.
Yes. There are thousands. So you're going to boot them all off the waiver? That would be my comment. The last thing I would say is even in a group home, which I've been in, I had to get the commissioner of the department and the director of ODES to a meeting and intimidate a group home agency to basically give me the modifications that I needed. So even in group homes, people aren't given the modifications they are needed, because providers of group homes are also saying we need a higher rate to do this. And the rate in a group home is considerably higher than shared living.
Representative Perry.
Yes, I just wanted to ask Josh, where are you staying right now? Are you in a apartment or are you in a group home?
I'm in a I'm living in a shared living home with a great provider who does great service, but it's not the best. But we're moving to hopefully a better situation soon. But it's still very frustrating because I have great advocacy skills and I've worked very hard for years on shared living to be a better program than what it is. I've met with the department over 7 times to discuss a rate increase. And there's no, and if I could add this piece of information, there's no CNA level of care in shared living, which there should be. You have more medically funded group homes, but you don't have the same for shared living. In my opinion, when a group home doesn't.
Josh, you're frozen again. We can't hear you either. I'm afraid.
Have more opportunity for community integration. Sorry, I don't want you. It seems like you have a question.
No, your audio is going in and out, Josh. So we're picking up most of what you're saying, but there are quite a few gaps due to.
All right, the weather here, the connection isn't the best. Sorry.
Any additional questions for Mr. Weidman or for Senator Libby? Seeing none, I would ask the committee if they have requests for any additional information for our analyst. Yes, Representative Craven.
Thank you, Madam Chair. I would like to know from the department more about the dollars that are unused, why they can't be reused, and yeah, thanks.
Thank you. Anyone else? Seeing no other hands up, I will close the public hearing on LD 1649 and thank the sponsor for bringing this forward and for Mr. Weidman for being here today. It was nice seeing you again here before the committee. At this point, I will open the public hearing on LD 1657. Looking for, and I see him, Representative Babich is here. We would ask you unmute yourself. Representative Babich.
Hey, Dale, how are you? Doing good, doing good.
Are you seeing and hearing me now, Madam Chair?
We are, Representative.
Good morning.
Welcome.
Well, thank you so much. Thank you so much. So formally, good morning, Senator Claxton and Representative Meyer and esteemed members of the Joint Standing Committee on Health and Human Services. My first time before you in a long time. My name is Christopher Babbage. I live in Kennebunk and I am privileged to represent House District 8. I'm before you today to introduce LD 1657, an act to protect the health, safety, and comfort of elderly residents and residents with disabilities by ensuring backup access to electrical power in certain facilities during power outages. Extended power outages can be disconcerting and even frightening for the most able-bodied of us. But for those who are dependent and vulnerable due to advanced age or disability, a power outage can be paralyzing and even traumatic. LD 1657 adds 3 sentences to main statute. Each of these 3 parts provides a minimum response to an emergency power outage specific to the type of facility. The heart of this bill is Section 2, adding to Title 22 MSRA subsection 7864. That requires all new construction of assisted living housing have a source of continuous emergency electrical power. The bill does not specify whether the emergency power, such as an emergency generator, should be for all or part of the facility. But it is the safety concern of residents on the 2nd and 3rd floor to have a working elevator. And it is in the best interest of all residents, even if it is in a designated common area, to have heat for warmth, refrigeration for medicines, and a charging place for cell phones for communication needs during an emergency. It's good to be able to contact family, for instance. For already existing housing, this bill does not create a new requirement for construction or retrofitting. However, the property management company or owner of an assisted living facility, in addition to current requirements that they have, licensing and so forth, shall create a plan that, as a minimum standard, includes an in-person well-being check for each resident of an assisted living facility within 2 hours of an unplanned continued loss of electric power. Section 1 of the bill specifies that for senior housing of more than 4 units that does not have emergency backup and is subsidized by public funds, an emergency plan be implemented that sets the minimum standard that an in-person well-being check for the occupant of the unit be conducted within 6 hours of an unplanned continued loss of electric power. The reason I am before you today is because of a constituent, a woman named June Burbank, who contacted me a year ago. Mrs. Burbank had taught in my school system. She was an early elementary teacher at Cousins School. She would be here today to relay her story, but she is recuperating at Maine Health's New England Rehab Center. She is in her mid to late 80s, is very sharp, is passionate about this bill, and I'll bet will listen in on the work session if she is able. In February 2020, June had suffered a pulmonary embolism and was placed in the assisted living unit at a York County facility. As she tells it, she was watching Jimmy Kimmel when the lights went out. Because of her condition, she sat in a power recliner with her legs elevated. Loss of power meant she couldn't move. It also meant there was no heat. When she got cold, she pressed her neck pendant. An attendant came and gave her a throw blanket. That was the last she saw of that attendant or anyone else for a long time. Unfortunately for June, her forced immobility kept her captive in that chair for many hours. Natural body functions could not be relieved by getting to the bathroom. She was trapped in the night. She pressed her pendant, called out for help. No one came. So she was trapped there, cold, wet, and miserable. She mentioned 6.5 hours, but it was actually 7:45 in the morning before she got help. People like June Burbank, who are in a vulnerable state of care, deserve that the state of Maine require of these enhanced care healthcare facilities that patients be guaranteed electrical power that ensures light, warmth, communication, refrigeration of needed meds, a flushing toilet, and a working elevator. I have provided this bill as a vehicle for you to address this problem with minor but important changes in the law. When Mrs. Burbank explained this incident to me, she was reaching out, hoping it could be addressed by the legislature in order to prevent other vulnerable patients from suffering unnecessarily. June asked me to ask you to imagine your mother trapped in this misery. I have presented to you my June Burbank bill. Because you scheduled this hearing on the day after Mother's Day, I hope you are receptive to her plea. In all seriousness, though, it is the obligation of the state to protect its most vulnerable, and I bring this to you to examine this issue. I will mention a postscript. I attached to the bill section 1 because the representative from Bethel, Representative Head, had sponsored a bill for backup generation requirements for all subsidized senior housing. The Honorable Eric Jorgensen, testifying for Maine Housing, neither for nor against that bill, explained retrofitting was expensive, that a requirement applied only for new construction was the most cost-effective approach, and that costs would vary depending on whether total or targeted backup emergency generation was installed. I learned from that testimony and modified this bill slightly from when I had written it back in December. This bill does not specify total backup generation. It does not require backup generation for existing facilities, nor for senior housing. I am trying to address new construction of assisted living facilities only. These are not addressed with required emergency backups. Those areas not addressed by having these required backups, I address with in-person well checks. Minimum standards as designated by the International Business Code, the IBC, which is part of MUBEC, require backup accessibility for a facility of more than 4 stories. I would want emergency backup power for my elderly and disabled loved one if they were placed on the 2nd, 3rd, or 4th floors where elevator use is so important. LD 1657 provides that backup emergency power be installed when constructing new facilities to address, at a minimum, targeted parts of a building to ensure egress, light, heat, electricity for refrigeration and communication, and for vulnerable residents of an assisted living facility. So I appreciate you hearing the bill. And if you have questions or concerns, I would be pleased to answer any questions. Thank you, Madam Chair.
Thank you, Representative. Representative Craven.
Thank you, Madam Chair. Thank you for bringing the bill forward. It's really a good bill. Do you know if there are a lot of facilities in Maine that don't have those safety standards in place now for people?
I don't have that information. I don't know if Maine Housing or anyone is in the attendee list today, but I was hoping that we might ask that from them for the work session.
Thank you.
I don't see anyone from Maine Housing here, Representative. Okay. Representative Zager.
Thank you so much, Madam Chair. Representative Babbage, thank you very much for bringing this bill forward. It seems like it's addressing a real need. If I understand from your testimony correctly, you're saying that an assisted living facility that is 4 stories or less in height does not need to have backup power. Is that correct?
I inquired of actually of DHHS, and DHHS contacted Maine Housing and was told, actually, I had heard it differently 2 ways. The first time I heard it, I think it was an Avesta construction manager who I thought said 6 stories or more would have a backup power generation required. Then I thought it was 4 or more. And in my most recent inquiry to DHHS, they inquired of Maine Housing and they got back to me that more than 4 requires it.
Okay, thank you very much.
Thank you.
Seeing no other hands up, Representative, and no one else in the queue to provide testimony, I would thank you for bringing this bill forward. Nice to see you here in front of the committee.
Yes, thank you so much, and great to see all of you, and happy Monday.
Yes, we'll see you at the work session.
Thank you very much.
Questions or requests for additional information by the committee to our analyst? Yes, Representative Perry.
Thank you. I guess I would like a definite definition, especially when it comes to assisted living or elderly housing, what the requirement for generation is. I know that there are homes sometimes that will have a generator. And if they're, I guess my other question is, if they do something in an assisted living that maybe has 2 stories, is it doable in a much less expensive way as well? I think Maine Housing may know that.
Seeing no other hands up, I will close the public hearing on LD 1657 and open the public hearing on LD 1608. Welcoming the bill's sponsor, Representative Sylvester. Welcome, Representative.
Thank you so much. Excellent. Let me switch my view so I can see my testimony again. Perfect. I want to thank you all for having me here today. I was chuckling a little bit at the beginning of your hearing because as I left my committee, we had no senators. I had to leave. We all had bills, and I had to turn over the chair to an unsuspecting Representative Pebworth to do her best with a bill of about 40 sponsors or 40 people to testify or so. So that is the committee environment at this point in the season. Senator Claxton and Representative Meyer, esteemed members of the Committee on Health and Human Services, my name is Representative Mike Sylvester, and I represent District 39, a part of Portland. Today, it is my great honor to introduce LD 1608, an act to expand the Maine Care program to cover all citizens of the state. I introduced a similar version of this bill in the 129th legislature, and the concept was merged with 2 other bills to study healthcare and passed out of committee ought to pass. That bill, in its final form, would have set up a legislative committee to study whether a single-payer system was possible. Like so many bills, it died in the COVID non-convening, and I was left to wonder how different things might have been during the pandemic if the committee had finished its work. Then I realized that I didn't need to wonder because healthcare in the pandemic had proved the worth of a system in which profit was not the key driver. If you or a loved one feared exposure to COVID, you were tested for free, whether you had insurance or not. If you wanted to be vaccinated, again, you were given the vaccine for free. Healthcare in the time of COVID has become a human right. And the question is why it hadn't always been. Now, colleagues, we're here today to ask a couple of important questions. The first is whether or not our present system of healthcare is working. In the 129th, we brought dozens of people who utilized the current for-profit healthcare system and who spent 5 hours telling the Health Insurance Committee the ways that the current system had failed them. It was not because any of the people who provide that care had failed. Our nurses, our CNAs and support staff, our physicians and physicians assistants, techs and custodians, they came to work every day with one thought: to make us well. Rather, the problem comes in the idea, and some would say the obscene idea, that healthcare cannot be provided without somebody making a profit. The idea that there would be shareholders in any part of the healthcare system would have been laughable for much of our healthcare history. It wasn't until the 1960s that hospital workers were even considered workers. Before that, hospitals and healthcare facilities were considered charities. Yet times change. Now there are several layers of profit between patients and their care. Is that okay? Is that the way that we want our healthcare system to work? Or is there a better way? That is what LD 1608 and what we therefore are in this committee room or via Zoom to discuss. Now, I have put in this bill because I believe that our current healthcare system does not work. I could have filled the, as I said before, I could have filled this room again today, and that's going to happen on Wednesday and insurance, but that's not what I wanted to do. You on this committee hear the tragedy of how people fall through the cracks every day. What I wanted to do was to have a discussion with you about expanding main care and let us come to our own conclusions. So to begin with, it probably makes sense to lay out how our healthcare system works today. Now, right now, if you get sick, your options about how to make yourself well again are predetermined by a series of prior choices. Say that I break my leg in a bad fall. Who I can go to help take care of this injury is determined largely by what insurance company and coverage I have selected. Can I go see my doctor that I selected beforehand from a pre-approved list that my insurance agrees to pay for? Can I go to the emergency room? Or will that not be covered if my predetermined physician doesn't approve beforehand? Are there certain hospitals where I'll pay more than others because of regionality or because they aren't on the list? What percentages of my x-rays, pain relief, cast, crushes, or space that I will take up in the hospital will my insurance cover, and which will I be responsible for? Will I be responsible for all of it because I haven't yet paid my deductible of $1,000, $2,000, $5,000 or more on my catastrophic coverage? If they give me antibiotics and some painkillers, does my coverage include pharmacy costs? What if I have to come back or when they take the cast off? What if the kind of treatment or cast that my doctor wants to give me isn't covered? I have a neighbor who had just such a situation and knew that he couldn't afford his deductible. He literally pushed his bone back in place against a rock and made his own cast out of duct tape and some resin he had laying around. It sounds like Maine ingenuity until you realize that he never walked correctly again and ended up losing half his foot to infection. The story ends with that infection eventually taking his life because he couldn't walk into a doctor to be treated without weighing his health against the cost. So that's our current system. I pay a price to a for-profit insurance company. I get a rationed portion of coverage for that money. There will almost assuredly be additional costs above what I've already paid. And those costs are mine to figure out or to leave to my caregivers to figure out when I can't afford to pay it. Many people who don't like that system talk instead about the kind of single payer system that they have in every other industrialized country in the world. So what is single payer? It's easiest to explain what it isn't. It isn't a state healthcare system where the state hires doctors and nurses, etc. Single payer is a system where the government, in this case, the state, pays the doctor and hospitals and pharmacies, but they all remain private. The citizens/patients pay a tax in some form, either to the state or out of their pay or in combination with their employer. You go to the doctor and get an x-ray, some meds, a cast, and a prescription. The state pays the hospital, the doctor, the pharmacy, etc. That's it. You, the patient, pay nothing more in a true single payer system. And some may say that's crazy, but you know what that system is. That's how it works for Medicare federally, for our military. There are a lot of models. And while everyone pays the taxes for our most needy, that is how main care works. You are sick and you qualify for care and they pay. What I want to do is improve main care and expand main care to make it accessible to every Mainer. So how does LD 1608 intend to do this? Well, let's start with the how. The bill authorizes the Department of Health and Human Services in consultation with other state departments to design an expansion of main care with the oversight of the Main Care for All Implementation Task Force. The task force is created of 9 legislators, 4 from the Senate, and 5 from the House of Representatives. They are the voting members of the task force. While there are a number of named groups from which the task force can name consultants to be of assistance to the task force, it is the elected officials of the state of Maine who get a vote, who get to control the directions and matters of inquiry, and get to shape the ultimate direction of the healthcare system that will serve us all. We have all seen and heard and perhaps been on task forces where the seats are filled with people who, while lovely and nice, have vested interest outside of the people's. So this task force puts the steering wheel in the hands of the folks who are responsible ultimately to the people who voted us here. It's tempting when writing such legislation to tell the department and that task force exactly how this system should work, and yet I used a broad stroke instead of narrow, prescriptive ones. This is in part because we would be doing something somewhat groundbreaking, and in part a check of humility on my part. I believe that you get the best people in a room and you let them work. I would rather have all roads open for the task force to drive down than a single restrictive path to get to the goals of a bill. Yet while I don't tell the task force or the department how to get there, I do provide a pretty clear map of the destination and some of the roads available. The final system must cover these things: hospital services, medical and other professional services furnished by participating providers, laboratory tests and imaging procedures, home health care for residents of the state, rehabilitative services for residents of the state receiving therapeutic care, prescription drugs and devices, mental health services, substance use disorder treatment, primary and acute dental services, vision appliances, including lenses, frames, and contact lenses, medical supplies, durable medical equipment, and selective assistive devices, and hospice care. Now, some might ask, how would we create such a system? It sounds like some sort of utopia. Well, we already have such a system, or darn close to it. It's called MaineCare, and it's helpful to think of that system at the launch of this point for this program, and there are no more experts on this system than you folks sitting here in this room. MaineCare is an incredibly successful and popular program. It has wide access to services, an established protocol, and the people who use it like it pretty well. Yet it has issues, particularly with amount and level of reimbursements, and that is the type of thing that the task force will need to grapple with improving. Yet when you look at the fact that some hospitals charge an average of 170% of cost for private insurance to cover the 70 cents or so on the dollar, depending on region, plus indigent care losses, you can see that there is room to get to paying a dollar on a dollar for care. In other words, paying what the care actually costs to deliver, rather than monkeying the system to cover the losses and make a profit for somebody. How would the system roll out? Again, it's helpful to think of MaineCare and the recent expansion. This system would roll out in 3 waves, or 3 expansions, in 2023, 2025, and 2027, according to income. The first wave would be the next tier of people who are not presently covered by MaineCare and who fall into that next third of the remaining state population. This is important for a couple of reasons, but because of who this next group is. They are the uninsured and the underinsured. They're young people, middle-aged people, and our elderly. They're heavy users and infrequent users. They are those who have coverage that they can't afford in the present system, or those who have coverage that has such large deductible that they can never meet it, or such a small scope of what is covered that they cannot use it. Even under the ACA, the plans that many people purchase leave them functionally uninsured, no matter the catastrophic plan they pay for. In other words, by implementing in tiers, you balance the risk pool. Many programs like this seek to provide care for the heaviest users in the insurance gap, which tilts the risk pool by age or health status. LD 1608 is proposing a more measured approach. As for the tiers that implement in 2025 and 2027, LD 1608 authorizes the department to seek a waiver to allow those folks outside that first or second implementation to buy into the plan at what I would anticipate would be a much lower cost than private insurance if they so chose. That would also help balance the plan, and the pool as cost would drive the market. Theoretically, we would be asking the federal government to allow us to make this plan our public option. How would you pay for it? Well, traditionally, such plans in nearly every other industrialized and some non-industrialized country in the world pay for their citizens with a payroll tax on citizens, employers, or a combination of both. We don't know what the task force will land upon, but we can assume that they will study all of these models. Oh, fantastic, great, a new tax. That's the wrong way of thinking about it, though. Taxes already pay for 60% of US healthcare coverage in the form of payouts and subsidized insurance according to Physicians for a National Health Plan. We are paying for a government system, but we aren't getting it. By creating a plan that phases in, but that everyone can purchase, we would have a new way of paying for what we already pay out, whether in employer contributions to insure their workers, employee contributions to fill the gap the employer can't, in deductibles and copays and miscellaneous out-of-pocket expenses that no one could know was part of their plan, in pharmaceutical costs that we pay for out of pocket and never have a right to negotiate, although programs like MaineCare get to negotiate them, and in the cost to our society of our citizens who wait too long to get care, who are treated in the emergency room for things that could have been prevented with regular treatments, or are denied or delayed by private insurance and pharmaceutical companies seeking to make a profit out of making sick people well. I don't have to tell anyone in this committee about the cost increases to private insurance that our businesses are reporting. In labor, we keep hearing 20% increases on our healthcare plans, which don't cover what we need or cover what we need at too much out of pocket to make it accessible. Won't the hospitals go broke? Well, the hospitals are already going broke. Before COVID, we had 2 hospitals in the state in the black. Everyone else operating under this system is hemorrhaging money. Much of the time, that is put on low reimbursement rates of Medicare and MaineCare, as well as unpaid and indigent care. Yet what would happen for hospitals and other providers if there was no unpaid care? What would happen if private insurance did not use delay, denial, and obtuse rules as a business model for making a profit? We have all gone to receive care and then found the form in our mail requesting additional information before the insurance company can pay. We've sat on the phone multiple times trying to get approval or fight a denial of payment. Heck, my dentist hires 3 people whose sole job is to help patients navigate the labyrinth of the insurance system. When I asked about the extra cost, she said that the relief to her patients and the bottom line from getting through the insurance company's gaming of the system, so she was paid in 6 months after providing the care instead of 6 years, was worth every penny. If the hospitals were paid fairly for costs and on time, what would the effect of that be on a rural hospital who works on an annual basis and not the multi-year basis it takes some companies to pay claims? We pay for this system in our health and in the overpricing of care to compensate for the delays and non-payments. The hospitals pay for it in their ability to fully staff and provide care because the check is always in the mail. Would having everyone on MaineCare ration care or have panels that make decisions about what care we can get? The answer is that since this task force will be designing the system, and I've already stated what needs to be covered, unless yourself and your colleagues design such a system, which you wouldn't probably then vote for, then no. Yet the truth is, folks, we ration healthcare in this country right now, but we do it by price rather than by design. We already have panels deciding what care we get, but they sit in cubicles with their bottom line rather than our health in mind. I have a lot to say more about this, but I won't because I'm going on quite a bit already, but this is an important subject. Lastly, and you'll be very glad to hear that, the fear will be raised by opponents that people would overuse such a system. Initially, that would be true because people who are priced out of the system now and go untreated would be able to see a doctor. Yet I repeat that we would no longer have indigent care or unpaid bills because everyone would be covered. We would not have a system that has 25% increases for marketing review of claims when doctors prescribe care or who look for any reason to say no. The bare point is that we get to return to a system where doctors and healthcare providers decide what care we get. People get care, tests and prescriptions, not because they demand them, but because a healthcare professional recommends them. If we have a system where the administration costs are much lower, healthcare professionals are driving care, Insurance companies aren't increasing rates at 20+% to cover the cost of a new building and CEO salaries, and pharmaceutical companies aren't raising 400% increases for an EpiPen. And people are seeking preventative care rather than emergency care. My guess is that it will roughly even out. People are overusing the system now, but they are overusing it either at the wrong end of the system for emergency or chronic treatment, or they are going into bankruptcy to use the system. You don't have to take my guess. 20+ years ago, this legislature authorized a study called the Mathematica study, which some of you may be familiar with. What did that study say? In part, it said that Maine could implement such a system and could afford it. It said that there would be initial costs, upfront costs, but that over time, the system would provide real savings. How? This conclusion was based on the then outrageous 8% annual increases that the study worried could not be sustained. Now we have 20% increases as a matter of course. That study can be reinstituted, and I would suggest that it be explicitly put in the text of the bill, but since that will add a fiscal cost, I wanted to leave that to the discretion of the committee. Finally, we can do this, whether it's a loan or because federal money becomes available, and we were able to say, look, here is what Maine has ready to go. We just need to think of the way healthcare should be rather than trying to manage the damage of what is. Now, I have added both the Mathematica study and a study by Maine All Care. And I hope that you will look at it. It says a number of very important things, including the fact that businesses would save money from having to go out each year and try to find new plans, that municipalities would save as much as $214 million, that the state might save as much as $1.5 billion, that people would receive, that care would be much more inclusive, that workers' comp costs would be cut in half. And that's just the tip of the iceberg. And so with that, I thank you so much for listening to this very detailed testimony, and I am happy to answer any questions that I can.
Thank you, Representative Sylvester. Questions for the bill's sponsor from the committee? I am seeing no hands up, Representative.
I guess I answered it all, and I appreciate, and maybe more than you wanted, but it's such an important issue. I appreciate your hearing this today, and thank you for your thoughtful consideration. I'll be there for the work session, and I'm happy to work with the committee on any amendments that you might see fit to see how we can get this group together to see whether or not this is a possibility for Maine once and for all. Thank you so much.
Thank you, Representative. As is our workflow, we'll go to any co-sponsors and fellow legislators, and then on to testimony in support, testimony in opposition, and then neither for nor against. With that, I will welcome Senator Chipman.
Great. Thank you, Representative Meyer, Senator Claxton, and colleagues on the Committee on Health and Human Services. I'm Senator Ben Chipman. I represent Senate District 27, which is part of the city of Portland. And I'm here today to speak as a co-sponsor, a very proud co-sponsor of this bill, LD 1608, an act to expand the Maine Care program to cover all citizens of the state. Healthcare is a basic human right. This expansion of Maine Care would guarantee affordable and quality care to all Maine citizens. If the COVID-19 crisis has shown us anything, is that investing in public health infrastructure is important and absolutely necessary. Insurance coverage ensures people have access to medical care without fear of financial burden. Imagine if you are sick and need to go to the doctor, but you can't because your insurance doesn't cover providers in your region. Or if you have an accident and must choose between going to the hospital or not because your deductible is too high. Or you contract a highly contagious disease, you can't go to the doctor to receive care because you can't afford the copay. Or you must choose between life-saving treatments and groceries because it's not covered in your insurance. Many Mainers opt against preventative care and early intervention for health matters because they're underinsured or have no health insurance at all. We've passed some important reforms, as many of you know, in the last few years here in the Maine legislature. It's great to have been part of that. And there are several bills this session to make some more improvements, which is great. And we also, as you know, finally passed Medicaid Maine Care expansion last session. and that was great as well. And all of this is important, but it is not enough. Even with Maine Care expansion, there are still tens of thousands of Maine residents with no health care coverage. We need to take action now to provide health care to every resident of our state. The United States is one of the only countries in the world without a universal health care program. And while there are proposals at the federal level, we could be waiting years for these proposals to be implemented. We cannot and should not wait. With this bill, Maine has the opportunity to set the standard for state-based health care. For these reasons, I urge you to support LD 1608 with an ought-to-pass recommendation. I'm happy to answer any questions you might have, and also happy to work with you on any amendments or aspects of this bill as we go through the process. Thank you.
Thank you, Senator. Yes, Representative Craven.
Thank you, Madam Chair. Thank you, Senator. So I think that there's a single payer and then that there's Maine Care. Obviously the federal government is in charge of Medicaid. And so I wonder if you could expand on the idea of Maine going forward with something that they don't have authority to do.
Well, I believe the bill calls for setting up a working group to look at all aspects of the bill, and I believe that we're looking at asking the federal government for some sort of waiver or permission that would be necessary in order to expand Maine Care to every resident, the tens of thousands that I talked about that don't currently have coverage, to be able to expand coverage to them through Maine Care. We'd obviously, I think, need some permission from the federal government to do that. We could ask for that permission. We could ask for a waiver to do that. And that's the point of the working group, is to look at that and what we would need to do. But I believe that we would have to get some permission, but I'd like us to ask for that permission and use this program. It's been a very successful program. Maine Care has worked really well in the state, and it'd be great to provide that Maine Care expansion that we did for the 70,000 residents to the other additional 50 or 60,000 that don't have any coverage today. We would provide that coverage to them as well.
Thank you.
Seeing no other hands up, thank you, Senator, for being here this morning.
Thank you.
We'll hear from a co-sponsor and our colleague, Representative Poppy Arford. Welcome, Poppy.
Thank you. Good morning, Senator Claxton, Representative Meyer, and esteemed colleagues of the Health and Human Services Committee. I'm Poppy Arford, honored to represent District 49, which embraces the western half of Brunswick. Thank you for this opportunity to speak with you as a proud co-sponsor in support of LD 1608, an act to expand the Maine Care program to cover all citizens of the state. I speak with you this morning trusting that what I say will adequately express how critical, how important the single payer policy of affordable, comprehensive, publicly funded healthcare for all Maine people put forward by LD 1608 is for our people and our state. How profoundly I believe that it is the right thing, the only just and equitable path forward to ensuring that every Mainer can afford the healthcare they need, be it medical, behavioral, dental or eye care, outpatient, inpatient, or residential. LD 1608 requires the state to implement this everyone in, no one left out policy through the Maine Care for All program. I also want to thank Representative Sylvester for this bill and for your testimony, which lays out the background, need for, and implementation phases in the Maine Care for All program. Out of respect to the committee and my agreement with all that Representative Sylvester has said, I will focus now on why I support LD 1608 and not repeat what has already been so well stated. I am 100% committed to single payer policy and passing legislation which implements it. Why? For starters, as much as I dislike campaign promises, I did make one and only one promise to my constituents while campaigning last year. The promise was that I would not come home from Augusta until single payer legislation was enacted, ensuring that comprehensive healthcare was affordable for every Mainer, every person in my district. Although complicated and challenging, there is no doubt in my mind that the Maine legislature has the intelligence, the work ethic, and the courage to deliver such transformative change in the way we finance and deliver healthcare in Maine. Since 2008, when my husband was diagnosed with cancer, and I was catapulted into being his caregiver and a patient advocate, I have represented healthcare consumers and patients' interests on many healthcare system improvement initiatives in Maine. This includes the statewide patient-centered medical home program, Aligning Forces for Quality, the state innovation model, the Maine Choosing Wisely community campaign, and serving on Maine Health Data Organization's Board of Directors and Consumer Advisory Group. I list them all to give any of you who may not know of these initiatives an idea of the breadth and depth of what has been done already. In one way or another, these programs have acted to identify how the current system falls short, then develop strategies and programs to fix it, to achieve the triple aim of improving patient experience of care, the health of populations, and to reduce the per capita cost of healthcare. Despite many committed people working very hard and millions of dollars spent by organizations, foundations, state and federal government on these efforts, in truth, we find ourselves today with incremental progress and a still fragmented, still unaffordable healthcare delivery and financing system. I have provided resources in my written testimony which provide further information if anybody would like to look at them later on. Bottom line is that even with all these improvement programs, getting the healthcare they need is still financially unacceptable for so many Maine people. The solution is found in a publicly funded single-payer financing system, which will act to realize both healthcare system improvement and affordability for all. Please support single-payer policy and LD 1608. Thank you, and I'm happy to answer questions.
Thank you, Representative Arford. Questions? Yes, Representative Lemelin.
Thank you. Yeah, I have one question for all three representatives and senator. March 23rd, 2010, I was told that the most amazing thing happened next to the resurrection of Jesus Christ, and that was the Affordable Care Act. Now, the Affordable Care Act promised every single American either free or discounted health care. So if we have the Affordable Care Act, which gives everybody health care, why do we need this bill?
Representative Sylvester, did you?
Yeah, yes, I'd be happy to take that. I think that like every good idea that tries to come into law, often through much struggle and compromise, this is sort of what I was talking about when I put together a committee of legislators, is that many folks, some of whom wanted that effort to succeed, some of whom did not want that effort to succeed, almost all of whom wanted to figure out how they could singularly make a profit out of the new plan coming together, cobbled together what we now see as the ACA. And I think what we will see coming forward are attempts to fix that. But I think that it starts with a fundamentally flawed premise that profit has a place in healthcare. As I said in my testimony, it wasn't even, hospitals were a charity until the 60s. It wasn't until the early 70s that the idea of profit in healthcare was even considered. And we find ourselves now where we are, where no one can be cared for unless somebody turns a dime. And so that, I think, is the problem with the ACA, in my humble opinion, not being an expert or a doctor or any of those things, but just a healthcare user and somebody who's watched legislation be made and end up with a product that sometimes doesn't meet everything that we wanted.
Thank you, Representative. Senator Chipman.
Yeah, thank you, Ms. Chair. And just to follow up on that, thank you for the question, Representative Lemelin. I would concur with that as well. You know, the Affordable Care Act is great and did a lot of good things. but it doesn't remove the profit from healthcare. And I've always believed, since the Mathematica study was passed back in the 90s, when I started sort of paying attention to the Maine legislature, that until we are willing to remove the profit from healthcare and use our collective buying power to negotiate prices, which is essentially what Medicaid and Medicare do. And Maine Care, as you know, is Maine's version of that. They use collective buying power to negotiate prices, co-pays, and things like that. And until we're willing to do that for all residents of the state and use our collective buying power to negotiate prices and get prices down, we will not be able to afford to cover everybody in the state and in this country. And that's what this bill is aiming to do by allowing everybody to have access to Maine Care. We can collectively use our buying power to get a better price. It's kind of like unit price. When you go and buy something, the unit price is always the lower price. And that's what we're looking to do with this, to remove the profit, to get the prices down so we can cover all of our citizens and save everybody a lot of money in the long run.
Thank you, Senator. Representative Arford?
Yeah, and all I will add is this. My belief is that if the Accountable Care Act in 2010 had included a single payer financing system, not only would we not be having this conversation today, but over the last 11 years, people would not have suffered horrifically trying to pay their healthcare bills. And some people would not have lost their lives because they were not able to get the care they needed because of their inability to afford it.
Thank you. Representative Lemelin?
Yes, thank you again. I appreciate your answers. My question is still, I feel like it's not quite answered. The Affordable Care Act guaranteed, in order to qualify for Maine Care, you have to be low income. And if you're low income, you qualify under the Affordable Care Act for free healthcare, whether it's a single person or a multiple family. So I'm still not quite sure why anybody should be on Maine Care, actually, according to the Affordable Care Act. So that's still my question. Why do we need this? Because these people should have free care. What am I missing?
So I'll just be very quick in that what the Affordable Care Act really offered was access to health care, to make sure that everyone was covered. But those two things as to what qualifies health care under the different plans that come out, in other words, what's covered and not, or what access is, whether or not you have the ability to pay for your deductibles, for your, to actually receive health care, that was not guaranteed. And that's what we see in the present bill, is that people may even have a policy that they pay for, but they can't afford to use it. And so to me, that's you're functionally uninsured. And so that, I think that we're talking about the same thing in some ways, but that I'm looking to go at it in a way that where people could buy into a program that we know is successful, that we know would be cheaper, and that we know as we did that we might be able to expand beyond, so that the public option in ACA would be Maine Care for everybody.
Thank you, Representative Sylvester.
Real quick, if I could ask one question. Do you have any idea the cost factor behind your plan? Do you have any ballpark figure?
Well, in this plan right now, I know what the costs would be for individuals, for example. A small employer would pay about 3%. In the study that was done by Maine All Care, I think that we'll need to redo that study, as I said, in order to look at Maine Care specifically. But in that text, it was a 3% of payroll for a small employer. For our largest employers in the state, it might be as big as 10%, but those are all just guesstimates in terms of trying to figure that out. But for the average person, their costs, both out of pocket, for example, someone that we're talking about who is at the lower end of the spectrum, their costs would be almost half, according to that study. And I encourage you to go ahead and look at it.
Thank you, Representative. We'll now move to testimony from the public in support of this LD, and we'll welcome Henk Gorhus.
Hello, thank you very much. Representative Meyer, Senator Claxton, and the rest of the Committee of Health and Human Services. My name is Hank Goyes, and I live in Auburn, Maine. and I'd like to speak in favor of 1608. I have sent a handout. It has a graph. Can I share screen or?
No, sir.
Okay, thank you. You will have a graph. And the first graphic on the handout is what goes into healthcare. And as this department deals with many of the aspects of, I'd say, the healthiness of our society, you folks especially know that, in a sense, healthcare, medical care is only 20% of one's health. That socioeconomic factors, physical environment, healthy behaviors all have a more prominent factor than direct healthcare that's delivered. So you on this committee especially understand and feel the burden of these other areas as you grapple with the entire scope of the healthiness of Maine. Your work here and through the broader legislative process is to get healthcare coverage and its financing worked out, so it fits better with the other issues you deal with on a daily basis that come before this committee. The United States has the distinction of having the most expensive healthcare system in the world. And when you look at my handout, graphic number 2, which compares US healthcare and life expectancy with all of our first world peers, that is the reason, the fact that the United States spends twice as much and lives anywhere from 3 to 5 years less than other countries. How can you have the most expensive product in the world and have such an underperforming metric? So the reason for healthcare reform is because the United States have a healthcare system that's too expensive and doesn't deliver. And Maine has the distinction of being in the top 20% of the expense of all the United States states. There's 4 items that undergird the success that other countries and our nearby Canadian provinces have had in achieving universal healthcare. Those are also outlined in my my handout and my policy. And those 4 things is you have to have one payer that provides that pays providers directly with no intermediate subcontracting, and no funding of competing risk-bearing entities, i.e. for-profit insurance companies, middlemen, and all of the pharmaceutical intermediaries that you've all heard of over the last 5 years. You have to have budgets for all the institutional providers, including hospitals, nursing homes, and community health providers. You have to have a simplified fee schedule for the individual, still independent providers. And you have to have negotiated prices for drugs and durable medical equipment, which is what everybody else in the world does, but us, under the rubric of Medicare being not allowed to.
30 seconds, please.
Is the 3-minute am I almost up, or can I go a little longer?
You've got 30 seconds, please.
Thank you very much. So this committee, be bold, okay? You hear all the citizen stories, you know the results of all this stuff. So I'd ask you to consider LD 1608 and work with the other legislative committees that will be dealing with healthcare reform over the next several years, and be bold so that you can do the good work that you do on the other 80% of the healthiness of Maine, other than the financing of the healthcare system. Thank you.
Thank you for being here. Questions from the committee? Yes, Representative Zager.
Thank you, Madam Chair. Dr. Gerhos, in your testimony in graph 2, you point out the irony that we're spending multiples compared to other peer nations. And can you please clarify for our understanding what we're getting for that in terms of life expectancy?
So there's a question of, how first world countries, they eat better than we do, they walk more than we do, some of them smoke more than we do, but what they do is they have a healthy environment. So I would say, Dr. Zager, you know that the United States provides as good as healthcare as any of the other countries do, and we all provide the same healthcare because we all do appendicitis the same way, and English is the language of business as well as healthcare, and the science is all the same. So it's not in the science of healthcare; it's in the science of your society that these folks live longer. I heard a graphic that said if we didn't shoot each other at the rate we do, we'd actually add a year to our life expectancy on that graph. But having said that, that's a societal factor, not a healthcare factor. So the question is, all of these other countries have simplified their healthcare and their financing to take care of the patients and to make it easy for that to happen. And all that other life expectancy thing, I think, is our, if you don't have an endocrinologist in Augusta because it's not cost effective, that's a healthcare item, that's a financing of healthcare that shows up in the life expectancy of people with diabetes and all the complications thereof in the central part of Maine. That's a direct cost of financing because in our system, endocrinologists don't make money for the institutions. Other specialists do. So if you don't want to have an endocrinologist because it doesn't make money, then you let that person go and concentrate on other money-making entities, because that's what the orientation of many aspects of our healthcare system is. That is a direct effect of the healthcare life expectancy of people in Maine because of our dysfunctional healthcare financing healthcare system.
And so the composite of all those factors is that we're spending, looks like on your graph, $7,500, $8,000 per person, but we're living a few years shorter than folks in Australia, Japan, Italy, et cetera.
Correct.
Okay, thank you very much.
Folks know all the determinants of healthcare on this committee. You know how that all adds up over time.
Thank you, Doctor. Seeing no other committee hands up, thanks for being here today. And
Thank you.
we will hear from Caitlin Morse. Welcome.
Good morning, Senator Claxton, Representative Meyer, and members of the Joint Standing Committee on Health and Human Services. My name is Caitlin Morse. I am a resident of Westbrook and the Policy Associate of the Alliance for Addiction and Mental Health Services. I am here to submit testimony in support of LD 1608, an act to expand the Maine Care program to cover all citizens of the state. At the Alliance, our members represent the full continuum of behavioral health, mental health, alcohol, other drug use and addiction treatment services, and peer recovery supports. The most pivotal work we do is work toward more equitable care. In particular, we've worked toward the triple aim: better care, better value, better health. Changes to insurance over the last 10 years through the Affordable Care Act and Maine Care expansion have made healthcare insurance more readily available for people who were previously uncovered. And what we've learned is that when people have the opportunity to access the behavioral healthcare services they need, they absolutely will. Take a look at the Maine Care expansion update. It reflects that 4,700 people who were impacted by the expansion took advantage of colonoscopy screenings. More than 6,000 took advantage of mammogram screens, but an impressive 42,015 people utilized their access to Maine Care in pursuit of behavioral health services. Clearly, there is still a long way to go. Consider 2021 rankings for healthcare access in the US News and World Report. Each of the New England states rank in the 10 best states for healthcare access, except for Maine, which ranks 27th in the country. Maine is also 27th in the country when it comes to the percentage of our residents who are enrolled in a health insurance plan. There are better options than there were just a few years ago, but there are still not enough good options for people who are seeking coverage in the state of Maine. In my own family, for example, we've had to face dilemmas when we've been offered employer-sponsored health insurance with premiums that were more than 25% of our take-home pay. Most recently, we were offered a $14,500 annual premium with a $6,000 deductible. We were functionally uninsured, but we're young and healthy, so we opted to save money for health care. But that decision, in making it, we had to recognize that a catastrophic incident could immediately ruin our financial status. When mental health concerns go untreated, there can be serious consequences, but nearly half of the 60 million adults and children living with mental health conditions in the United States go without any treatment. Even mild mental health problems can lead to a lower life expectancy. People with severe mental health disorders have a 10 to 25-year reduction in life expectancy. Maine Care for All would get the job done. Thank you.
Thank you. Seeing no hands up from the committee, we appreciate your being here today. And we will hear from Philip Caper. Philip Caper? Mr. Caper?
There we go. Can you hear me?
There you go. We can hear you, but we can't see you.
Well, I'll have to fix that, I guess. There you go. Okay, thank you.
Welcome.
Senator Claxton and Representative Meyer, thanks for having me. I've submitted a written testimony, and you've heard a lot of it already from the excellent presentations that have been made. But let me just focus on a couple of things that haven't been mentioned. I'm Dr. Philip Caper. I'm an internist, retired internist, a founding member of Maine All Care. I helped found the organization, and a health policy expert who I think is recognized nationally and internationally. I think you've heard a lot about all the pathologies in the healthcare system as we have it now. And I will not go over those anymore because you've already heard about it. But I will talk about something that was touched upon earlier. One of the problems with the Affordable Care Act is that it is based on a faulty premise, and that is that healthcare is a market like any other market. That is a premise that has been disproved repeatedly. 60 years ago, economist Kenneth Arrow showed how healthcare markets cannot work in healthcare because of the moral hazard of insurance. People don't feel they're paying for their services themselves often, and also because of poor information. In 2001, economist George Agerlof was awarded the Nobel Prize for demonstrating that in markets where there's a large asymmetry in information between the sellers and the buyers, that is, the sellers have much more information than the buyers do. Those markets, quality suffered in those markets, and they inevitably became corrupt. That's what's happened in healthcare. Despite the valiant efforts of healthcare workers all over the country, the system fights us at every turn, and it's creating a great deal of burnout among physicians and other healthcare workers. I became interested a number of years ago in why is this so hard to change? I mean, this has been a fight that's been going on since the Roosevelt administration in this country. So I convened a panel of some of the leading healthcare workers in the country that was held at the National Press Club and sponsored by the National Academy of Social Insurance, which I also helped to found.
30 seconds, please.
Okay. Our problem is largely cultural. And we have the panel that I was a part of identified a number of factors that have created barriers to change. The first is an apathy and the lack of empathy. And many of these barriers are cultural. Second is fear of loss of income or profits or of government incompetence. People are afraid that the healthcare system is too complicated to be run by the government. What we're advocating is a federalized financing system, not a takeover of the healthcare system. And anger is another one, particularly anger directed at people who some people think aren't worthy of tax-supported care. So structural racism. Market ideology has been tremendously damaging to healthcare, with the belief that markets can work in healthcare. Well, I will tell you unequivocally that markets cannot and will not and have not worked. They never will because of the basic information disparity. Finally, people are ignorant about how the healthcare system works. Only a few consultants and navigators understand how it really works. And finally, there is greed, the structure of capitalism in the belief that there's no such thing as too much profit to be made by a publicly traded company. And these are things we have to get our hands around. I think we are better than that. I think we can do it and join all the other wealthy countries in making healthcare a right. The MESEP study, which has been referenced repeatedly, showed that we can, without changing federal law, we can improve existing coverage for Medicare and Medicaid beneficiaries and for people with employment-based insurance. And we could save $1.5 billion in Maine in the first year of full implementation and more into the future. We can also get rid of medical underwriting, which is insurance speak for discriminating against people who are sick who will become sick or are likely to become sick. That makes sense for automobile insurance and homeowners insurance. It does not make sense for healthcare to blame the victim and penalize people who are likely to use the system. That's perfectly sound principle in most insurance, but not in healthcare. So I support and hope you vote ought to pass on the LD 1608. It's time for a remake of the system, and this bill is a very good start at that process.
Thank you, Dr. Caper. Questions from the committee? Seeing none, we appreciate your being here today.
Thank you.
That concludes testimony in support of the bill. We'll move to testimony in opposition and welcome Jeff Austin. Mr. Austin.
Good morning, Chair Meyer, members of the committee. My name is Jeff Austin. I'm here on behalf of the Maine Hospital Association to speak in opposition to the bill. Let me try to address a few points. No system is perfect. A single payer system will not cure all of the ills and all of the problems that you heard about in the proponent's testimony. Issues like deductibles and networks and prior authorization, those kind of things don't go away in a single payer system. But let me start on a positive note. Our members' experience is that with systems like Medicaid and Medicare, those aspects of health insurance are much more manageable and reasonable than they are in commercial insurance. And so single payer can be appealing if the administrative tasks are consistent with Medicare and Medicaid today, because those are so much more manageable than those identical issues like prior authorization in the commercial world. But no system is perfect. If it were, you wouldn't have 150 bills in front of you this session. Even Medicaid, you had a bill fighting about getting people decent ostomy bags and ostomy services. You'll never get rid of everything that's difficult in the healthcare system. The VA was mentioned, one of the more scandal-plagued systems we have. So if there are appealing things, and there are about a single payer to our members, why are we opposed? First, I'm a little confused because we're talking about expanding Maine Care. The principal aspect of Maine Care finances is that the state picks up 1/3 of the cost and the federal government picks up 2/3 of the cost. And presumably that would be what the waiver was seeking, was that the federal government would pick up its share of costs when we moved all of Maine's population into Medicaid. I don't see a reason why the federal government would pick up 2/3 of the share of healthcare costs for the entire commercial population. I'm not sure what that is, but it's probably over 700,000 people. But then the Mathematica study was referenced. I'm not an expert in it. I haven't looked at it in a while, but that's not asking the federal government to pick up 2/3 of the cost. So are we putting everybody into Medicaid where the feds pick up 2/3 or not? I'm a little confused on that. Probably the biggest objection we have, and Representative Sylvester alluded to it, is that Medicaid pays around 70 cents on the dollar. And he talked about getting to $1 for a dollar.
Please.
$1 of cost being met with $1 of reimbursement. Our request on these bills every time they come up is show us. Give our members the confidence to work with you. There's nothing stopping you from getting to $1 for a dollar today, except the will to find the money to do it. That's difficult. But show us that we can work together. Please don't promise us that we're going to get to $1 for a dollar after we scrap commercial insurance, which is how we stay solvent. A lot of talk about profitability. I think our members' concern is solvency. And so show us that you can provide $1 for a dollar in the existing Medicaid program. And I think you'll find more providers willing to work with you on big reforms such as that proposed in the bill. With that, I will wrap my testimony. I'd be happy to take any questions.
Thank you. Questions from the committee for Jeff Austin? Seeing none, thanks for being here today.
Thank you.
Moving to testimony neither for nor against, but with additional information for the committee, we would welcome Gwen Simons.
Good morning, Senator Claxton, Representative Meyer, and honorable members of the HHS committee. I am the lobbyist for the main chapter of the American Physical Therapy Association. First of all, thank you for last week for passing our bill LD 498 to increase the reimbursement under main care for PT services. We are neither for nor against this bill. I think is a very important bill for your consideration. But as indicated in the effort we had to make to come back to the legislature to get an increase in our rates after 20 years of not having any increases, the reimbursement levels is a concern. What we would like is to be represented on the task force. The task force calls for representatives from the physician, hospital, and nursing communities, but it does not appear to have representation from allied health professionals or particularly the private practices, because those are the practices that don't always have a voice, certainly not in reimbursement with commercial payers. So we would like you to consider adding a position for either a group of allied healthcare professionals who are in private practice, and certainly include physical therapists in that group. Thank you for that consideration. That's all that I had to add.
Thank you. Questions for Ms. Simons? Seeing none, appreciate your being here today. Concluding testimony this morning is Thomas Stern. Welcome. You are on mute, sir. Still on mute.
Better
There you
now?
go. Better
Thank
now.
you so much, and much appreciated. Good morning, Madam Chair, Senator Claxton, members of the committee. My name, as you hear, is Tom Stern. I'm a retired primary care physician and health economist. I live in Bridgeton. And I want to say that Representative Sylvester's LD 1608 implicitly acknowledges the devastating failings of our current healthcare coverage system here in Maine, which is a hodgepodge of expensive and administratively burdened services with varied benefits and large out-of-pocket layouts that effectively deny services when needed, even if the person is insured, and which also fails to control skyrocketing inflation. It does seek to move us forward towards universal, fair, and affordable coverage by encouraging enrollment in an expanded form of main care, our current Medicaid vehicle. As written, LD 1608 does not as yet explicitly speak to important core questions that will impact its potential success in achieving efficient, financially sound distribution of benefits to all Mainers. And to list a couple, number one, will the benefits package be robust and uniform? I think by implication from Representative Sylvester's comments, the likelihood is yes. Number two, if providers can elect to or not to participate, as we say, will this plan be or become anything beyond yet another insurance option that further adds to bureaucratic overhead? And I want to add to the question asked about the Affordable Care Act, the single piece of lowest hanging money fruit that exists in our system now is the 20 to 25% administrative cost of managing in a commercial insurance system, whether it's in the bellies of the insurance company, the doctor's offices, or the hospital basements. Number three, what will this coverage system cost individuals? It's a fair question. And how will the funds be collected? Will there be copays and deductibles built into the system that encourage deferring visits? Maine Medicaid does not currently have that, and I hope the future would be the same. Number four, what would be the role of private insurers and managed care organizations in this new plan? Will their participation further or hinder the goals for cost efficiency and the goal that care should be treated as a public good? And last, how will LD 1608 affect and coexist with Medicare, the Veterans Administration coverage system, and other federally supported or mandated programs? I want to point out to at least one member of your committee that Ro Khanna's HR 5010 is an augmented federal proposition that seeks to allow states to experiment and include even Medicare in a single state solution to this. I understand some of these concerns will be addressed by DHHS as in the bill, but the RFP to help address that, it sounds like in the bill will be self-funded as opposed to publicly funded. So I am concerned a little that this will be inviting well-endowed stakeholders to the table, which I hope will not be the case. In sum, I support the goals of LD 1608 dramatically, strongly, fervently, and stand in awe of Representative Sylvester and Senator Chipman's proposal. If we truly wish to achieve universal coverage that's publicly funded, privately provided, saves 20 cents on the dollar of administrative bureaucratic overhead, and that will achieve significant cost savings, even with expanded coverage, we must work towards having a single payer, buy-in from all providers, a fair standard fee schedule, budgets for institutions that are fair, and negotiated price controls. I thank you for your consideration, and I welcome any questions you might ask me.
Thank you. Questions for Dr. Stern? Seeing none, thanks for being here today.
Pleasure.
That will conclude testimony on LD 1608. I would ask the committee for any requests for additional information from our analyst, Anna Broom. Yes, Representative Craven.
Thank you. I'd like to know if any other state has attempted something like this, and yeah, so thanks.
Seeing no other hands up, I will close the public hearing on LD 1608 and turn to Ms. Broom for any additional work we have before us today.
We actually have 3 amendment reviews to do.
Okay.
So I'm going to do the first 2 and then Erin will hop on for the 3rd one. So I am going to pull up this one first. This is LD 910. I'm sorry, let me just, you can't even see the title, can you? So this is the I can do this. I'm sorry, I'm just trying to find the Representative Brennan's bill on general assistance that the majority voted. This is the 90% reimbursement kicking in at a certain level of reimbursement. So this is, as I mentioned, just the, it was a fiscal note only request. And this is the majority report. The minority report was not to pass. So that is what the fiscal note looks like.
Thank you.
That one. Okay. And the second one is a little more complicated. So this is, I believe, Representative Perry's bill. I think it was last time anyway. It has 3 parts to it. This is a nursing facility bill. I'm going to skip past this and go to the appropriation section. This is a unanimous report, and it has 3 pieces to it. So the first part is the appropriations that is related to the certificate need of not needing a certificate of need approval. This is the bed banking side of it. And so I did talk to Luke about this since this is really his world. And you can see all 3 parts of it there, the general fund, federal side, and the other special revenue. So there has been a decrease in the number of beds in nursing homes in the last few years. We're not talking about COVID specifically, but prior to that with nursing home closures or wing closures or whatever. And if those beds were to come back online, there have been a number of changes in reimbursement since those beds went offline. So they are now more expensive to bring back online. And that's why there is a cost to that side of it. I know it sort of seems like, oh, you used to have those beds, wouldn't they still be covered? But they are actually more expensive to bring back on. Those of you that have been in the legislature for a little while are aware of the fact there's been a number of changes to things like reimbursement and COLAs and so on for nursing facilities. And so those beds are now more expensive. So that's the first piece of it. The second piece
is related to the medical director. This is the changing the statute from allowing nursing facilities to claim up to $10,000 for a medical director for main care. So the statute doesn't limit the amount that a nursing facility can pay to their medical director. It limits the amount that main care will reimburse the medical director for. So as you know, nursing facilities are not 100%, well, not very often, 100% main care. So there are some private pay sides to that. So the point that I'm just making here is that the medical director main care reimbursement is only for the main care portion of the medical director costs. And all of those, we think, meet that $10,000 cap for that's currently in statute for the main care side. This is changing it so that there is no limit. So I know that you heard about the cap within a cap, because this comes under the routine costs. But realistically, there would be no point to putting this in if it didn't have some kind of financial impact and benefit to nursing facilities. So that's why the fiscal office and the department believe that there is a cost to increasing the medical director side. Increasing the cap, or rather removing the cap altogether. And then the third part is the easiest one to explain. This is moving the cloud-based software system from routine costs to fixed costs. Routine costs, as we just mentioned, have a cap, and fixed costs are generally a pass-through. So this is the easiest one to explain because when you do run into your routine cap and you can't include all of your computer costs, you have nowhere to go. But if you had it as a fixed cost, then you would have, because it's a pass-through generally, they would be able to be reimbursed for those. So that's the easiest side to understand. So hopefully that all makes sense to you, and that fiscal note is something that you are okay with, and that one is ready to go out the door as well, because that was a fiscal note only amendment, and it was, as I mentioned, a unanimous report. So unless somebody throws up their hands in the air and says, no, that one is ready to go.
Seeing no hands up with questions or hands being thrown up into the air. Thank you, Anna. I believe Erin.
Hi there.
Hello.
So Anna's all done with her too. Is that right? Okay, great. Good timing. Okay, so I have the majority and minority amendments on LD 206, which was the major substantive rule reviewing the lead testing in school drinking water standards. So you can see here that the resolve changed the this is the majority report, changed the standard of 15 parts per billion to 4 parts per billion, and this lists all the sections of the rule where that term is updated. Also, you decided to change language around pre-stagnation flushing. And so it removes reference to water being motionless not longer than 18 hours, and instead says that excessive flushing of pipes may not take place immediately prior to the minimum 8-hour non-usage period in order to ensure that the sample represents a period of normal use. And you also changed the notification period of time required by schools from within 10 days to as soon as practicable within 5 days. And then finally, it removes the emergency preamble and clause, which are they're automatically drafted that way, and you've taken that off. There is no fiscal impact to this amended resolve. So that's the majority report. I have to, for some reason, my computer wouldn't let me open them both at the same time. So I'm gonna reshare my screen This is the minority report on LD 206. It replaces 15 parts per billion with 10 parts per billion and all those same sections that set the level in the drinking water. It also, similar to the majority or identical to the majority report, replaces the notice requirement of within 10 days to as soon as practical within 5 days. And it also removes the emergency provision on the resolve. And there is also no fiscal impact. So these are also ready to go out the door unless anyone has a problem.
Thank you, Erin. I am seeing no hands up. So I would entertain a motion to adjourn.
Moved.
Second.
And I would just advise the committee Democrats, we will be caucusing at 1 o'clock on the link sent by Senator Claxton. And all in favor of adjourning for today? We'll see you tomorrow morning.